This is Sg2 Perspectives, a weekly conversation between the Sg2 intelligence team and industry thought leaders about the biggest trends in healthcare. We're happy you joined us today. Enjoy the episode.
It's concerning. Are we going to end up having retail deserts across the country? Is it a space we as providers want to fill? The margin isn't all that attractive, but if we set this up correctly and the scale and volume, how does that work with our platform? What is our community and our mission driving us to do? Some organizations are thinking about and pursuing actively. Others are waiting and seeing what's going to happen.
Welcome to Sg2 Perspectives. I'm your host for today's episode, Jayme Zage. Pharmacy is a very important part of the health system business. And I wanted to bring my colleagues, Justin Cassidy and Brian Esser, to share with our audience the research and findings that they've shared through a recent webinar about the pharmacy system of care. Welcome, Justin and Brian.
Thanks so much for having us. Great to see you, Jayme.
Let's start by telling our audience who maybe aren't involved in pharmacy why pharmacy is so important to the health system, especially as we move into that ambulatory footprint.
Speaking to a recent blog post from our Kaufman Hall colleagues, 60% of health system revenue is now ambulatory. Hospital-based health systems are primarily the outpatient enterprise from at least a revenue perspective. That ambulatory first mindset that Sg2 has been espousing, coupled with the inpatient-outpatient shift of procedures, there's also an inpatient-outpatient shift of pharmacy services. Much of this is being driven by abundant clinical innovation. Any researchers that are listening, Jayme and I have experience in this space. It takes decades for these to materialize. We're seeing these miracle cures get into patients for the first time. Cell and gene therapies, we're also seeing new types of injectable medicines, anti-obesity medicines, peptides, even small molecule innovation, new drugs for schizophrenia, pain management. There's a lot of innovation to capitalize on to enable access to patients to treat and cure conditions in ways that are more precise and potentially even cure their conditions. Brian, from a financial perspective, what's the deal here?
The discussion around pharmacy has grown exponentially, particularly within the finance teams and tangentially with the CSOs and strategy teams, as we've come to a realization that pharmacy isn't just an acute care cost-oriented discussion. It's a meaningful revenue and margin driver, and how we hold that out to the business, what capital infusions we need to make into this line of business, and how do we think about all of the regulatory dynamics at play is becoming a multi-stakeholder discussion. There's also demand. Consumers are realizing the benefits, these miraculous drugs, and consumers actively want access to these. They would love it if it came from their traditional established primary care and other providers within your health system. But if not, they know there's other alternatives and pathways to accessing these drugs. We understand that consumers are pushing very meaningfully in the space. Employers are reaching out and saying, this is constituting a significant amount of overall spend within my health benefit. I want to offer meaningful benefits to my employees, but I need to rein in some of these escalating costs within pharmacy. Health system leaders, help me understand how you're doing that and what we can do to partner in a more proactive and meaningful way. So it's coming throughout the entire ether of how our business model works, and we need to get a much better handle on it.
It's striking. We talk to leaders, when they look at this math, some systems are starting to lose money on inpatient procedural activity. They're subsidizing the inpatient surgical services with outpatient pharmacy revenue. We recently internally did an analysis using outpatient clinical database data. We're looking at the medical administration of pharmacy, so infusions, injections, and ingestions done in clinic. Of that 60% of total system revenue being ambulatory, 27% was attributed to procedures at academic medical centers, 26% was to pharmacy. Ambulatory surgery and pharmacy services garnering equal revenue. There's has historically been an equal strategic focus. What has happened recently is the elevation of chief pharmacy officers to start education, awareness, and integration effort to coordinate strategic activities across the system of care.
That's fantastic data. And when you brought that forward in the webinar, it shocked me, but I was like, okay, this makes intuitive sense, but it's interesting to see it on paper. From the business model perspective, pharmacy, yes, a revenue driver, margin generator, that is real true. But also, what kind of business model are you pursuing? Most of us are still in a very heavily dominated fee-for-service environment, and this plays very well. But as our payer mix shifts much more towards governmental, the idea of value-based care is becoming more and more important or pertinent, and is now the right time. And where is pharmacy's role within the value-based care spectrum? As we're looking at escalating costs, chronic conditions, the more acute population, can pharmacy help us mitigate cost increases, drive new shared savings, and hopefully within ACOs or other similar models, be accruing to our benefit? Thinking about it in multiple payment scheme is also critical.
So let's go back to that system of care. There are these different cohorts that you've put together. Let's start with inpatient and the hospital-centric piece. What are the key strategies here?
Cost savings is where the historical work has been. And this has been the area that we've had the most concerted effort over the past 10, 15, 20 years. But it really comes down on the inpatient side, benchmarking, reducing variation, making sure the right things are showing up in your acute centers and things that shouldn't be there are not showing up on the acute side. So the idea of committees and stewardship continues to be important within the acute care center.
No, the stewardship program is absolutely essential. It's evolved from, say, opioid stewardship to high-cost drugs, making sure that unnecessary utilization is mitigated wherever possible. Patients are administered drugs in a more consumer-friendly and outpatient environment through beds-to-beds programs when and where available. On the hospital side, there's also this higher acute type of medicine being offered. We talked about that innovation, the cell and gene therapies. Our brilliant pharmacy colleagues at Vizient have coined this ultra-specialty pharmacy. The extreme intensive resources and wraparound workforce that's required, there are multidisciplinary teams that are challenging for smaller systems to support these new therapeutic interventions. Each new drug is a therapy. It requires either a surgical or a particular type of infusion. Some are very invasive, require several months of hospitalization, an advanced bone marrow transplant with gene therapy replacement. For systems large and small, they have to make a decision. Scale these services, become a comprehensive gene therapy hub, scoping to what can actually make a margin and offered in the long term, or skedaddle. Get out of this altogether, deselect. You still have to partner for referrals to those tertiary hubs, however. At the end of the day, there'll probably be fewer centers that do these therapies. They'll be able to scale that multidisciplinary team and be referral hubs.
That's interesting, Justin. Let's flip to the other side, true ambulatory. What is the focus there? Because the plethora of medications is going to be prescription drugs. And where does the hospital play when you see so much of pharmacy in the ambulatory space being prescription driven?
The ambulatory space encompasses general buckets. The first is about specialty pharmacy and specialty light. A list of drugs that require a lot of clinical activity to support their administration and support on the front end, managing patients longitudinally with perhaps a genetic condition, something like cystic fibrosis. We have amazing precision medicines available today to treat, but they do require expertise to ensure the patients that can benefit are receiving the right medicine. Others would be HIV prevention medicines and treatments, advanced infectious disease. But more than anything, it's biologic infusion medicines. And the reason that we're familiar with them is because of direct-to-consumer advertising. Household familiarity is what's driving some consumer-directed demand in the infusion space. But there are legitimate treatments being used for autoimmune and inflammatory conditions that have never been able to treat and cause remission of disease. Think about rheumatological disease, gastroenterology, even dermatology. But every single service line will be impacted by an infusion therapy. These are terrific opportunities for hospital-based pharmacies to deliver superior quality, rendering these services, curating those medicines that require special handling considerations in order to maintain their efficacy and wraparound support for patients. On the flip side, the most volume for pharmacy is in the retail space. Brian, we've seen some large-scale closures of Rite Aid, Walgreens saying they're going to contract their footprint by half, now being bought out by private equity.
It's concerning. Are we going to end up having retail deserts across the country if some of these retailers pull out and don't offer it? Is it a space we as providers want to fill? The margin isn't all that attractive, but if we set this up correctly and the scale and volume, how does that work with our platform? What is our community and our mission driving us to do? Some organizations are thinking about and pursuing actively. Others are waiting and seeing what's going to happen. But there's also a lot of the mail order factor into this. You cut the data down to see what is happening in the space and what is your strategic advice.
We have access to Medicare fee-for-service claims data for Part D, where those pharmacy claims are rendered by site of care. And it's really 3/4, a good 75% are community or retail pharmacies. It could be a Walgreens, CVS. It could be a hospital-owned center. There's probably about 20% of services being offered by long-term care pharmacies. Those could be part of an ACO, roughly the order of 5 to 8% mail order. It's a sizable business, one that many health systems are thinking about getting into. But there you're competing with logistics from an Amazon that is offering these types of pharmacy delivery services. Those large, more vertically integrated pharmacies like CVS, Aetna, channeling patients to their mail order pharmacy in order to manage spend of their own insured patients. That specialty piece, small sliver of that overall pie.
That's interesting because then that retail space is ripe for innovation in a way to deliver it more effectively and continue to support the overall ambulatory business of the health system.
That's exactly right. The comprehensiveness of pharmacy services is something that is at the bleeding edge of pharmacy strategy today. The idea that building that referral channel to specialty pharmacy and even ultra specialty, serving longitudinal patients' needs. The business model is retaining referrals to those more specialized visits. The Walgreens Rite Aid, they were often losing money on every script filled in the retail space because these are inexpensive generic medicines that don't have much margin to be made. That's why they're challenged is to contract their physical footprint for a variety of reasons. It has changed their business model considerably.
Their goal of driving us all through the candy aisles, that's where the margin's going to be made, and the way back to get the medications.
The supplements fit into the third category in that ambulatory space, which is wellness. There's a robust black market, but also gray market for pharmacy. The gray market in the compounding pharmacy space, we've seen explode in the last year with anti-obesity medicines, back and forth with FDA and the pharmaceutical companies because of these compounding pharmacies offering them at a lower cost or through Medi-Spas. This is a wild west of wellness that is only now starting to play itself out.
What is the underlying issue the consumer or patient is trying to solve on their own that you're not able to bring to them in a meaningful way? Yes, we know the ultra specialty and we know the specialty market, and we're trying to understand what's going on there because we understand the revenue to margin drivers and the financial fundamentals. But some of these other markets that aren't as coordinated or outside our purview seems to be indicating we're underserving our patient population. How do we communicate that we're at least aware of that and we want to meet them where they're at and understand their issues that they're solving independently without us?
There's a lot of folks seeking pain management, and these patients fall through cracks in our system of care. Recently, we actually created an acute care pain management landscape publication at Sg2, looking at the need for this pain management service, a comprehensive, well-managed program. This has been a success in the hospital, expanding to the ambulatory, meeting patient needs. Common condition driving folks into care is pain, and being able to address that with a more precise care plan as a part of a multidisciplinary team is an absolute and real inspirational opportunity.
The other side of that, Brian, integrated medicine piece and how that comes into play. There's certainly drive by consumers for the wellness type of initiative, the preventative, anti-aging type approaches, but it hasn't gone through clinical trials. That's the other side of wellness that you do see in the pharmacy aisles when you walk up to the pharmacy counter. Given this range of potential opportunities to support that revenue growth, what do strategic planners need to know about the pharmacy business as they work with their chief pharmacy officer to set up that portfolio of services more appropriately?
Monitor the clinical pipeline. Our Vizient colleagues do a brilliant job doing this as a part of the spend management outlook. That has a great list of what's coming down the pike and will be impactful for clinical care. Some of these cell and gene therapies, say for hemophilia, replaces infusions. One type of miracle cure can supplant another that might be a stable revenue stream for some. Our forecasters at Sg2 take all of this into account. The second is there has been a very strong and sustained pharmaceutical shift in many areas. The most obvious, the anti-obesity medicines taking a significant drop in bariatric surgery, 48% from one estimate over a 3-year period. There are many other pharmaceutical shifts like antibiotics treating appendicitis, immunotherapies, and mRNA therapeutics supplanting surgical oncology, even new oral meds that might replace in-clinic antimicrobial injections, maybe one of the more out there ones, but new arthroscopic injections of regenerative cocktails that could potentially cure arthritis being produced by University of Colorado investigators. It's interesting how that could cannibalize our existing business models. By offering more pharmacy, we could replace surgery in some respects.
3 things came to mind, all starting with letter C. First one, capital. Limited capital. If we're going to invest in ultra specialty, obviously on the ambulatory side, all of these are going to require some level of build out, collection of care teams. Some might be advanced care teams, especially in the ultra specialty area. How are you going to deploy capital across all the needs you currently have to break fix stuff at the hospital, strategic growth on the ambulatory side, digital investments, AI, and now pharmacy? All of these are opportunities. How do we think deploying our dollars in the most effective way? What ROI is expected, and where does pharmacy stack up? We need to understand how do we think about capital deployment and efficient use of capital on a go-forward basis. Second one, cash flow. Some of these drugs are expensive. They're novel. Justin, like you said, the impact is great, but there is a cost dynamic. Can you as a system afford the potential delay or lag between serving the patient and the reimbursement for these therapeutics? There could be a cash flow break more on the pediatric side, but also academics. How do you manage and can you absorb that? And what does that mean if you can't? And the equity and just making sure that you can hold this out to the population in the most meaningful way and those that need this drug or therapeutic. And the third one is confusion. Justin, you and I don't get to partner all the time, but from a strategy lens, is it a medical benefit? Is it a pharmacy benefit? What does it do? There's just a lot of confusion in the space, even for me. And as I tried to come in and think through it, I was like, wow, there's a lot to unpack here. And for the strategy teams, do you really feel comfortable having these discussions? And if not, even more reason to partner in a meaningful way with your pharmacy colleagues who understand and live and breathe this space. That dialogue is even more important.
I think that's a great way to end our conversation today. Thank you, Brian and Justin, for joining me on this episode of Sg2 Perspectives. And thank you, listeners, as always. See you next time.
Thanks for listening to this episode of Sg2 Perspectives. Please don't hesitate to reach out to Sg2 if you have questions or suggestions for future episodes.